Um, Folks on YouTube, it's your lucky day today because both the case discussant and myself have to leave exactly on time. So the intros will be short. I'm kidding. No, they're never going to be short. Today is an all internal affair. And I'm so excited to welcome back to the discussant seat our beloved Hee Mun. Hee Mun's been part of the CP Solvers for a very long time. I've lost track of what discussion number this is for you, He, honestly. But if you were looking at my screen, you would just see hearts flying from left, right, center from all the CP Solvers team members, and I think nothing summarizes that better than what he means to this community. But for those of you on the outside, you may know her as probably the most religious attendee of VMR over time. I think the only time that he's not on VMR is when she's actively taking care of other not virtual patients. And we've come to just admire her for her incredible kindness, dedication to medicine, and the fact that she seems to know the diagnosis very early in, in most of these cases. So we're very excited to have you today. Let me hand the mic to you to say hello, and then we will introduce the other contributors to this space.
Yeah, hi, my name is Hee Mun. I'm IMC from Korea, and I'm applying internal medicine this year. And next week I'm starting CCU, and my weakness is EKG. And here, the master of EKG, David, is here. So, so I'm very excited to learn the case from him, and I'm so grateful that he always teaches EKG. So I want to improve on EKG.
Look at that smile that you just brought out of Debbie. That's awesome. The master of the EKGs, Mike, to you, my friend. You want to say hi?
Hi, friends. I'm sorry, this is not an EKG case. But yeah, I hope you'll enjoy it.
Wonderful. Well, today on scribing is one of our newest Academy members, Jillian. Let me hand the mic to you to tell folks a little bit about yourself, and we'll take it from there.
Hello, I'm Jillian. I'm a second year medical student at Mount Sinai in New York, and I'm excited to be scribing today.
Thank you for doing so. And across an ocean is Magnus, who's doing teaching points. Mic to you, Magnus.
Hello, everyone. My name is Magnus. I'm a medical doctor from Denmark, Copenhagen. And yeah, very happy to be here. Very happy to do the teaching points today.
All right, guys, let's rock. Hey, we kept this to 4 minutes. Impressive. David, we're ready whenever you are. Let's rock and roll.
Okay, so this is a 52-year-old female who was admitted to nephrology with AKI. So before I'll tell you the rest of the history, I'll just give you the labs, the basic labs that were the reason to admit her. So the creatinine was 1.46. The urea was 35, and the urine more than 200 white blood cells per microliter, more than 200 red blood cells per microliter, and dysmorphic red blood cells like into 30% or so, and a urine protein creatinine ratio of 2 milligrams per milligram. I'll leave it there and just tell you later how you should know.
Wow, what a start. Incredible. So where's your mind with the information you have so far?
So this a patient, 52 years old female, was admitted, and then it's acute kidney injury, and I would like to see whether this acute kidney is like baseline, whether she's having any chronic kidney disease before, and then it's just happening acute kidney disease. First of all, I'd like to know that, and then if we look at the creatine 1.46 and WBC, so if it is a really high WBC, I worry about pyuria, like acute infection, inflammation. And then I think he mentioned about the dysmorphic sediment, right? So whether it's related with the ATN, possibly, and RBC is more than 200, so maybe there will be hematuria too. So yeah, so those are the things that in my mind. And acute kidney injury, uh, I would like to see whether infectious cause for this one, like pyelonephritis, or maybe it could be any prerenal cause too, and also granular disease like hematuria and WBC. So and then interstitial nephritis is also possible, and ATN. Yeah, those are in my mind. Please give your wisdom, Ravi.
Yeah, no, I think that all those things are on the list for sure. I'm curious, if you were just to list the most common cause of AKI in the hospital, what's your understanding of the most common cause?
Yes, I've seen in an AKI, its most common cause was the prerenal like dehydration, and
Right.
also the ATN from the
Yeah.
from prerenal to causing the
Right.
ischemia and dehydration ATN, and also medication also can cause a AKI, and also contrast
Yeah.
with a person who's having baseline of chronic kidney disease or having like AKI.
Yeah, I share that with you. And I think that that's just a powerful place to begin clinical reasoning, which is that the most common causes are pre-renal kidney injury from a hemodynamic insult or medications. And both of those things can go on to progress to cause ATN. And so that's the base rate of disease. Let me ask you separately to analyze independently of the AKI, pyuria. So if all you know about a patient is they have pyuria, what would be the most common cause for pyuria?
I guess it could be like UTI
Mhm.
or it could be a pyelonephritis. If you're asking for organism, it could be like E. coli,
Yeah.
usually.
Yeah, I think that if we keep it at the big picture level to try to see what sort of zoomed out progress we can make, it's interesting that pyuria implies an infection in the renal apparatus, either in the bladder or in the kidney. And I'm curious, Hemun, what percentage of patients do you think who have a UTI have acute kidney injury?
Not much.
Yeah, exactly. And I think that's the point, right? Is you really have to step back and say um, that your reflex is to consider when you have a patient with pyuria, you know for a fact that there's some inflammation happening in their genitourinary system. Their urine is literally on fire.
Mm.
And the question is, why? And we often start with just with prioritizing infection like we do in any form of inflammation. But we have to use the landscape here that the patient has acute kidney injury to influence how we view that pyuria. And you just said it. The vast majority of patients with pyuria, when it represents the most common cause, UTI, don't have AKI. And that's because there's no reason for a patient with cystitis to have AKI unless they're dehydrated. There's no reason for patients with pyelonephritis, which in the vast majority of people affects only one kidney. And since the other kidney is working, the kidney function is perturbed. So the most common cause of pyuria and AKI is that the patient has an infection and has developed pre-renal AKI.
Mhm.
And I think that's the most important piece of analyzing the rest of this data, which is to ask yourself, just because I'm finding these urinary abnormalities, doesn't mean that these urinary abnormalities are a clue to the cause of the AKI. They may have separate explanations. So while it is often very tempting to say the combination of pyuria and AKI suggests interstitial nephritis, The reality is the vast majority of people who have pyuria and AKI have two independent explanations for both those things. Pyuria is from an infection, and the AKI is from pre-renal dehydration. And they are linked in a longer chain, but not a direct one, AIN. And so maybe we can do the same exact exercise with the hematuria. So what do you think the hematuria most common cause outside of AKI? What do you think the most common cause of hematuria is?
I think it could be nephritis or glomerular usually glomerulonephritis.
I think that's, if you ask yourself how common is glomerulonephritis, it's exceptionally rare. Much, 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 much less common, some more common causes of hematuria. So if you were to zoom out and think outpatient clinic, um, no symptoms, what would cause hematuria in that setting?
Uh, Cystitis.
Mhm. Yeah, for
And
sure.
yeah,
Cystitis.
interstitial nephritis, like from the medication.
Yeah. By far and away, the most common cause of hematuria is trauma or urinary trauma. So Foley placements,
Um,
kidney stones. And you're right that cystitis can do it too, often featuring pyuria and hematuria. But you can think of, if you ask yourself, why would the kidney be bleeding? It's often because there's something irritating the bladder or the ureteral wall. So just like the GI tract, you're asking yourself, what's making an irritation? And in the GI tract, it's usually an ulcer or a cancer. And in the kidney, it's the same. There's something irritating it mechanically, often a Foley or a stone or something of that nature. So when somebody has hematuria and AKI, the overlap is also often that they're completely unrelated. That a patient has a kidney stone, is in pain, not eating or drinking, and gets AKI from the dehydration. So most of the time when you have hematuria and AKI, they're not related at all. But as you said earlier on, you can relate them through the presence of glomerulonephritis. So here, we don't just have that the patient has hematuria, we also have that they have dysmorphic red blood cells. So how does that finding the dysmorphic red blood cells, what does that do for you?
So like a body brown, like a dysmorphic, will be like ATN. So like dehydration from the pre-renal to causing the ischemia, or any toxic like causing the ATN. Yeah. So please give us your wisdom, Ravi.
And no, you're right that muddy brown casts are actually very common and they're strongly associated with ATN. Dysmorphic red blood cells is a different entity, and what that refers to is when the shape of the red blood cell is abnormal, often because it's going through a glomerulus that's bleeding. So the dysmorphic red blood cells is consistent with the hypothesis that you said earlier, which is the patient might have glomerulonephritis. And you see that David didn't just give us that the patient has dysmorphic red blood cells, he told us what percentage are dysmorphic. Because dysmorphic red blood cells are actually not uncommon, and they're not that specific for glomerulonephritis. But once you start to have a larger and larger number of these cells, you have to worry more and more about glomerulonephritis. So I think if we were to summarize our conversation, I think the vast majority of patients with AKI have pre-renal disease. And the question is, what significance do these findings of hematuria and pyuria have? The vast majority of patients with hematuria and pyuria have a separate independent cause for those things. However, when you clarify that the hematuria is both associated with dysmorphic red blood cells and with proteinuria, you have to start to worry about glomerular disease. If you also find that the pyuria is associated with a negative urine culture, you might have to then wonder, the patient is inflamed in their kidney, but the culture is negative. Do they also have a non-infectious cause of their pyuria? So what I'm really eager to hear about is, of course, the rest of the landscape. But we've taken the hematuria and added two qualifiers, dysmorphic and proteinuria. I'm really eager to see if the pyuria also has a qualifier of culture positive or culture negative. And if it's culture positive, then we might be able to discard the pyuria. If it's culture negative, then I think we have to put our thinking hats on. A lot of information in this aliquot that you can get out of it, but let's see what David has for us next.
Discussion. So I'll give you a little bit of her past medical history and then complete the HPI. So this patient had asthma, well controlled, and had also iron deficiency anemia, presumably from gynecological origin, and also had rheumatoid arthritis on methotrexate, 10 milligrams per week. So yes, this patient was seen by her room doctor, and they've seen that they've only checked basic lab evaluation, and they've seen that AKI, along with neutropenia of 2,500, and also mild anemia and thrombopenia around 11.5 of red blood cell, hemoglobin and thrombocytopenia of 80,000. So this patient was transferred to nephrology to see what do they think about the AKI, and they admitted her. I'll tell you a little bit more about her history. Regarding the meds, she's on methotrexate, that this was withheld 1 month ago when the room doctors saw that neutropenia. The family history is nothing remarkable there. She lives in Spain and has no recent trouble. She works in a poultry industry. She has 2 dogs and three like how do you say that? Agaporni is a norm that a name that you like 3 little birds with her. And yeah, she's non-smoker, doesn't drink any alcohol or do not have any other drug use. And yeah, I'll stop there and tell the rest of the history.
Super fascinating. Maybe there's a lot to focus on. I'm just curious what the past medical history, how did that influence your thinking?
Medical rheumatoid arthritis and methotrexate, right? So I'm not sure about the rheumatoid arthritis, but like since David mentioned about like a little bit pancytopenia, is it right? Right. So whether it's like I've seen SLE with the acute kidney injury causing the, like pancytopenia. So maybe rheumatoid arthritis may be related, or like any like rheumatoid arthritis like causing the HLH or yeah, just looking at the history, like those are in my mind, and also anemia. I'm not sure about methotrexate can cause maybe like bone marrow suppression, maybe.
Right.
Yeah, what do you think?
Yeah, you made a lot of very good, quick associations there. I think the first thing to emphasize that you did was just that rheumatoid arthritis is always a presumed diagnosis. And the strength of the diagnosis is increased if you have seropositivity, RF and CCP, and if you have classic X-ray features. But what rheumatoid arthritis really is this entity that's saying that a patient has only autoimmune destruction of their joints. But the problem is many autoimmune diseases begin as an arthritic syndrome, only later to evolve into something extra articular. So it's not uncommon or unheard of to have a diagnosis of presumed rheumatoid arthritis before you start to develop more visceral complications of autoimmunity that then have the rheumatologist update the diagnosis from RA to something else. But it's also very possible, as you said, that because you have one autoimmune disease, that you subsequently develop another one like lupus. And so, whenever you're in the world of rheumatoid arthritis, until you know more information about serostatus and x-rays, I encourage you to say presumed and to be open to the arthritis evolving into a systemic visceral autoimmune disease like inflammatory myositis, lupus, scleroderma, uh, and also be open to the possibility that a patient can get another autoimmune disease. However, as you mentioned, as soon as a patient is treated with an autoimmune disease, the treatments for autoimmune diseases are not mild. And even though, so my wife is a rheumatology fellow, and I asked her to tell me what her favorite immunosuppressing medication is in terms of risk profile. And just yesterday, she said methotrexate. Because of all the medications he prescribes for long-acting immunosuppression, methotrexate is the most mild. And so I find it ironic that 12 hours later we're discussing this case, where, as you said, that the links of methotrexate to the syndrome are very plausible. Oh, Leah just also added one other pearl that methotrexate is also the most studied. So Leah's likely in Kara's camp. But if somebody is going to develop complications from methotrexate, it would be exactly what we are seeing. It has a bone marrow suppressive effect, and which is why the rheumatologist held it because it inhibits folate synthesis. It also is linked with acute kidney injury through a different mechanism, and that mechanism is precipitation of crystalline nephropathy. So you can get crystals deposit in the interstitium. And that both of them are not idiosyncratic. They're both dose-related phenomena. So what can happen is that somebody gets AKI for other reasons, say pre-renal. They start to accidentally accumulate their methotrexate, which can then cause a range of toxicities. As a fun side pearl, the most common reason why patients get methotrexate excess or overdose is because of kidney injury, but you can also accumulate methotrexate in large effusions. It pools in those. I had a case in medical school of somebody who developed an RA-related pleural effusion, and subsequently a lot of his methotrexate hid in that effusion, ultimately resulting in methotrexate toxicity. So that's another way. So all these things are just risk profiles, but one thing that I think both he and I are struggling with are the idea that that rheumatoid arthritis tends to spare the kidney and does not cause some of the things that we were talking about directly, glomerulonephritis, so on and so forth. Neither does the methotrexate. So I'm right there with you, and I share that same analysis. I think there's some interesting things in the social history about infection risk, but I think we don't know the syndrome well enough yet to speculate. So why don't we hand the mic to David to give us more information, and we'll start to see what relevance we can make of it. But like you, I think the RA is very likely to influence her case, and the methotrexate the same. So let's keep track of them.
Yes, great. So going to the HPI, so this patient reported, like, when admitted, in the last 3 months, she had malaise and asthenia. She also developed epigastric pain that was worsening in the postprandial moment. Had also had some intermittent vomiting, and has also noted brown urine. In the last month or so, she's had several episodes of fever, like 2, 3 per week, mostly in the nights, and with sweating. Has also had some weight loss, about 5 kilograms in the last 2 months. and didn't report any other symptom like no chest pain, no dyspnea, um, and only when asked was referred also some oral lesions intermittently in the last 2 months. Yeah, I'll give you briefly the physical examination because yeah, doesn't there's not too much. So the temperature was 37 on admission. The heart rate was 80. The blood pressure was 150/85. Was the SpO2 was normal, 96 on room air. He was alert and oriented. He was feeling okay, no in acute distress. Cardiovascular and pulmonary exams were normal. And abdominal exam revealed like huge mass in the epigastric and left upper quadrant. Yeah, and the new exam was normal and skin was normal, no edema, and didn't have any skin lesions at that time, neither in the oral area or something like that. I'll leave you there and just yeah.
I should make one question and one comment, and then I'll see what you're thinking. Debbie, can you describe what you felt in the epigastric? I know you felt a mass, or was it like a focal, small, or what did you feel?
Yeah, was it deep? Like I can this was a deep like mass non painful like
Uh,
in the epigastric and yeah, right
I
upper quadrant flank and sorry, left upper quadrant and left flank
okay.
really yeah, consistent
Uh,
with, should I
yeah, yeah.
say?
No, no, it's okay. You don't have to say no. I just was curious if, because I want you to stay authentic to what you did, right? Like you don't know exactly what it is. But what I was trying to understand is that it's not something that's bulging the skin, that you have to push to feel it. I see.
Yep.
Yeah, that's very, very helpful. Thank you so much. Um, the comment I wanted to make is I think, all of you who know Debbie know that he's been investing in his diagnostic and clinical reasoning for what feels like centuries. And you're seeing the powerful lesson he's teaching us about how much the history influences our thinking. So I think you're going to hear a lot of fascinating thoughts from he. I know that she's about to share some really cool wisdom with you all, and I want everyone to do me a favor and pay attention to what he first said and what she's about to say now. And what's the point? The point is you cannot solve a problem unless you use your patient's words to guide you. It is impossible. And the reasons for that are very, very simple. No modern technology can come even close to millions and millions of years of fine-tuning the body to understand what's going on. Not even close. So to try to illustrate that, I will hand the mic to you. I'm curious, what did this finally talking to the patient, how did it influence your calculus?
Yeah, I mean, how can I, like, I'm sure you know all the answer, but I still, like, studying and David, you are doing a wonderful job. And yeah, for the like weight loss and fever, I wonder whether it's B symptom like late with the lymphoma or non-Hodgkin lymphoma, since the mass in epigastric and also acute kidney, nephritis, or those are related with some lymphoma, and also left flank pain. I think it could be maybe a splenomegaly, causing the pancytopenia. Thinking maybe could be possible. And also, I want to rule out, like, I want to find out whether it's also infection related because of fever, HIV, hepatitis B and C, and also like TB and what would be another infection? CMV, EBV, yeah, those are the causing the pancytopenia. So I want to rule out the infection. But yeah, with the pancytopenia and mass and B symptom, I feel like it's more likely pointing to lymphoma or like malignancy. Yeah, please give us your wisdom, Rabih.
Do you have, I mean, you exactly as I sensed you would do, you did. None of those things you were saying when we got the labs, right? Because I think what happens to people is that you focus on what's acute and you forget the subacute. So when you're analyzing AKI with hematuria, proteinuria, you don't think about the B symptoms. Now, this kidney dysfunction is not the whole problem. It's a small part of a massive systemic problem. So, sorry for the noise. Give me 1 second. Every Thursday around the time of VMR, there's street cleaning here. So this massive truck, I don't know if you guys can hear it. It's so loud. But I'd love to ask you now. So you're leaning towards lymphoma, but I'm curious, if you are managing this patient, which category would you prioritize first? Infection, autoimmune, or cancer? What would be your initial evaluation?
Mm, I really want to find out this mass, so I would like to do abdominal CT.
Good, very good.
Yeah.
Very good. Yeah, I think
Mhm.
clarifying this mass is really key. I think that, as you said, with it being in the left upper quadrant and the patient having pancytopenia, that is so tempting to wonder if that's the spleen. And I think that the probability of that is very high when you feel a bulge in that area. And when the spleen gets big, it starts to move towards the epigastric region as well. So I think clarifying that is going to be very, very key. For me, I think you cannot lose any focus in ruling out an infection in this patient. She's immunosuppressed, not extremely immunosuppressed, but certainly immunosuppressed. And you have a febrile pancytopenic syndrome in a patient who has immunosuppression. So the focus really has to be on where is she infected. And I think we have to use the time course to our advantage because this is if this is an infection, it's a subacute infection. And so whenever you think subacute infection, you should listen to what he said. She gave you the two common causes of a subacute infection. The first is mononucleosis viruses like HIV, EBV, and CMV. But much more common than those are granulomatous infection. The single most common portal of entry for granulomatous infections is the lungs, tuberculosis, histoplasmosis, so on and so forth. And so for me, what I'm really interested is, of course, reassessing what her labs are and getting both a CT chest and a CT abdomen pelvis. The abdomen pelvis you explained, the chest is because I want to understand, does she have evidence of granulomatous infection in her lung? But let's not forget why she's here. She's here because of her kidney injury, and we already know she is inflamed in her kidney. And that opens up the possibility that she actually has one of these infections affecting her kidney. And so let's keep track of that as a possibility. So spleen, maybe, lungs, maybe, and let's see if the kidney is also involved. And so finally, would love to see what her urine culture is, because culture negative pyuria is a very fascinating diagnostic space. All right, Mike, to you, David. Very, very intrigued to this case.
Okay, so we'll give you a bunch of labs and some imaging. So when admitted, the white blood cells were 2000, yeah, with normal differentials. The hemoglobin was 11. The platelets were 63,000. And NCV was 88. Regarding the CMP, that sodium and potassium chloride bicarb were normal. The creatinine was 1.5. The urea was 40. Glucose was 110. Calcium was 9.2, corrected. Well, 8.4 non-corrected. AST, ALT, alk-phos, and bilirubin were normal. The albumin was 3. Total protein was 8.7. CRP was 3, which is just very mildly elevated. ESR was more than 140. That was the limit of normal. The limit of determination, I mean. The LDH was 280, yes, mildly elevated. CK was normal. TSH was also normal. Complements were normal. Yeah, C3 was, let me see. C3 was 137 and C4 was 11. The rheumatoid factor was positive, but mildly 40. CCP was negative. And I'll give you also the, well, IgA was normal. IgG was pretty high, 4,000. IgM was a little bit low, 30. So the urine, so pretty similar at the previous one. There was more than 200 red blood cells per microliter. A little bit less, but more than between 100 and 200 white blood cells per microliter. The urine culture was negative. Didn't show at that time dysmorphic RBCs, and the urine protein creatinine ratio was 1.8. And I'll give you also just that the chest X-ray was normal, and the abdomen ultrasound showed splenomegaly of 22 centimeters, with some focal liver lesions that were thought to be hemangiomas, and nothing else were normal, and no hydronephrosis, no normal atrophied kidneys, or yeah.
Super. Wow, fascinating case study. May I just ask real quick, do you happen to have an albumin to creatinine ratio or just the protein?
Yes, so the albumin was 1 milligram per gram. So yeah, also like it.
Okay, gotcha. Thank you. Very helpful. So the urine protein to creatinine ratio was 1.8. The albumin creatinine ratio was 1. Okay, thank you very much. All right, Hugh, what did this information do for you?
Yeah, so it said urine protein creatinine ratio is not high enough for nephrotic, but it could be nephrotic, right?
Mhm.
Yeah, and also I was wondering, is it C3 is normal, like 137,
Yeah,
or is
both are
it
normal.
both normal? So, but yeah, when the complement and the IgG high, I was IgG high. I was thinking it could be remind like autoimmune kind of SLE or rheumatoid, or could be infection, TB, or like HIV.
Mhm.
Yeah, and then also like could also think of like plasma cell, like MGUS or multiple myeloma. and polyclonal, we can think of other liver disease too. So those are in my mind, and also I guess the left flank was splenomegaly was showing that. So yeah, so I just want to find out more like the infection that you mentioned, whether it was positive or negative. Blood culture was negative, but I didn't hear like HIV, hepatitis, CMV, EBV. David, can you like tell us like was it test was done or not?
I promise you, David has very meticulously planned what he's going to say and not say. I trust him tremendously. So he's either intentionally withholding that from you or gonna give it to you later, I promise. I'm right there with you, He. I think you're very fixated on infection, and I think that's very wise. I think the question is what progress did we make based on the exam? And I think your suspicion that this is splenomegaly has been confirmed. And so now you're definitely dealing with a reticuloendothelial disease. And so it's interesting. How many times have we on VMR diagnosed reticuloendothelial disease, granulomatous infection, cancer, lymphoma with this kind of kidney dysfunction? And the answer, I think, is 0. It's very, very rare to have reticuloendothelial disease show up with this kind of AKI. And I think that combination of things helps us make progress. And so we've talked a lot about the kinds of things that can cause pancytopenia and splenomegaly, maybe 100 times on VMR. But I think we haven't really discussed what the combination of hematuria and pyuria signifies. And where in the kidney is this coming from? And so we said earlier that hematuria plus AKI prioritize nephritis. And you said nephrosis is not here because of the proteinuria, which is correct. But pyuria prioritizes interstitial nephritis, right? So which one do you think is the mechanism here? Do you think this patient has more nephritis, glomerular nephritis, or more has interstitial nephritis? Which one are you leaning towards?
Well, that's a really difficult
It
question.
is. I will tell you before you answer, it's actually impossible. I don't think you can know, but that's why I want to emphasize which one are you leaning towards, not committing to.
I will more cling to nephritis. Yes. I don't know. It's like kind of infections. I'm thinking of is like as you mentioned, granulomatous disease. I think it'll more relate with the nephritis. Maybe I'm wrong, but
And which nephritis, interstitial nephritis or glomerular nephritis? Which one?
glomerular
I
nephritis.
see. So can you think of an infection that causes a granulomatous infection that causes glomerular nephritis?
Oh, HIV is for sure.
Yes.
But maybe TB. I'm still thinking. I'm not sure whether it could be TB or
Yeah.
yeah.
Okay,
Yeah,
can you think of an infection that causes interstitial nephritis?
interstitial nephritis. Um, uh, I would say TB still.
Yes. So it's actually, you're right that if you're thinking HIV or hepatitis C or hepatitis B, glomerulonephritis is your friend. If you're thinking TB, histo, brucella, interstitial nephritis is your friend. So this really depends on which one are you leaning more towards. Are you leaning more towards HIV, hepatitis B, hepatitis C, which are not granulomatous, or are you leaning more towards the granulomatous? What are you trying to feel? What do you think?
Okay, Rabbi, I will go for interstitial nephritis.
Yeah. Let me
Yeah.
try to explain why. Okay. So when you have glomerulonephritis, you often have pure hematuria and proteinuria. It's very rare to get pyuria. And the reasons for that are very nebulous, and I've never really understood them. But the simple way I can help you remember it, but maybe not fully understand it, is white blood cells are much larger than red blood cells and rarely leak into the urine from glomerulonephritis. Because what glomerulonephritis is just that there's bleeding in the capillaries. And the capillaries usually are not permeable enough for white blood cells to get in. They're permeable enough for protein to leak. They're permeable enough for red blood cells to leak. And in fact, they make the red blood cells squishy and dysmorphic, but they're not permeable enough for white blood cells to leak. Interstitial nephritis is inflammation of the interstitium that commonly results in spillover inflammation into the urine. It's no different than somebody who has a pneumonia who develops spillover inflammation in the pleura, causing a pleural effusion. Same thing happens in the urine. And sometimes, just like when you do a thoracentesis and a pleural effusion, you sometimes get red blood cells in an empyema. That's because when you have inflammation, you have bleeding. So if you're trying to say, when I have both hematuria and pyuria, is it more common for glomerulonephritis to have pyuria or more common for interstitial nephritis to have hematuria? And it's definitely the latter. It is way, way, way more likely for interstitial nephritis to have some bleeding associated with it than it is for glomerular nephritis to have pyuria associated. But there are two other clues on this repeat urinalysis that we should prioritize interstitial nephritis. The first is that the dysmorphic red blood cells are gone. They're no longer there. Remember, they were 30%, now they're 0. If you have glomerulonephritis, you always have dysmorphic red blood cells. The other thing is that the urine culture is negative. And the third thing is the difference between the urine protein and the urine albumin. So if we adjust the numbers to make the math simple, the urine protein to creatinine ratio is 2, and the urine albumin to creatinine ratio is 1. If you have pure glomerular bleeding, you tend to have more than 70 or 80% of your urine protein be albumin, because glomerular bleeding causes selective disproportional loss of albumin. In this case here, there is notable amount of albuminuria, but the albuminuria is in proportion to all protein lost rather than selective albumin loss. So here, the fact that the albumin is nearly half the total protein in the urine suggests against a selective loss of albumin, arguing against the glomerulus being the culprit. So there are many reasons to prioritize interstitial nephritis here. The first is the syndrome of a granulomatous infection. Our current working hypothesis, our hypothesis may change, is more consistent with it. And then close analysis of the urinalysis, the combination of hematuria and pyuria, the negativity of the urine culture, the lack of dysmorphic red blood cells, and the lack of selective albuminuria all suggest interstitial nephritis. The problem with interstitial nephritis, you cannot make any progress on it serologically. Complements are normal, they are normal, everything is normal. So you really have to, when you have interstitial nephritis in the context of a systemic syndrome, you really have to follow the path of the systemic syndrome. So I wanted to spend more time on that because I think analyzing this UA as much as possible is a rare opportunity. I know we only have a few minutes left, so let me just ask David. David, how many aliquots do you have left? Just one and then diagnosis? Or, okay, let me hand you the mic now and then you can give us your...
Yeah, so we'll give you the last aliquot and then reveal the diagnosis. The CT thorax abdomen pelvis just revealed splenomegaly and some small lymphadenopathy in the right axillary area and iliac area, but nothing else. The more deep analysis, lab analysis showed polyclonal increase in gamma globulins regarding the gamma gap that exists. the kappa and lambda change were increased, but the ratio was normal. The ANA was positive 1 to 160 and cytoplasmatic pattern. The dsDNA was strongly positive, and these intramer antibodies were also strongly positive, but the rest of the ANA were negative. Also, well, anti-myositis antibodies were negative. Anti-beta glycoprotein and the cardiolipin were negative. ANCA antibody was positive by immunofluorescence with an atypical pattern. MPO was negative and PR3 was positive into 180 by ELISA. And Coombs was also positive. IgG, C3 was negative. And the serologic workup, HIV, HPV, HCV, EBV, CNV were negative. Syphilis was also negative. And yeah, Coxiella and parvovirus were also negative. Yeah, I think there's one more test that gives the diagnosis. Right? We have, yeah. Ravi, I can hear you.
Oh, sorry. Yeah. Is it good now?
Yeah.
Thank you. This is such an incredible case study. Thank you so much. So what are you thinking now with all these very fascinating tests?
Well, with a small lymphadenopathy in the right axial inguinal area, I always consider like the infection like TB is in my mind. HIV, HCV, all those are negative, but he didn't mention TB. And also ANA is positive, so anti-double strand DNA is strongly positive, means like SLE could be there too. And Coombs IgG positive. If I'm right, is it IgG is also related with the SLE or I just cannot remember. Yeah, so could be it could be both. But also I cannot let TB go because lymphadenopathy and David didn't mention that. So
Very good.
yeah.
Very good. I'm so proud of you because I think that it could be very easy to ascribe a higher level of confidence and say that this patient definitely has an autoimmune disease. Well, and why not? She has a history of RA. She has pancytopenia, hematuria, AKI, a discordant ESR and CRP, lymphadenopathy, and oral ulcers. How is this not lupus? Either as the whole story for the whole time, since the patient's RF is only mildly positive, or that she has an overlap. How could it be anything else? The question is, what are the counter arguments to an autoimmune disease? The first is that you have to do a thorough epidemiology-based infectious evaluation always. So that's one thing. The other thing is, how common is it in lupus to have splenomegaly of 22 centimeters? It's rare. It can happen as part of lupus evolving into HLH, but it's a big red flag. It's also unusual to have this degree of lupus involvement of the kidney with normal complements. It's also unusual to have such marked antibody positivity with ANA double-stranded DNA, but also the ANCA being positive with negative subserologies. Those are all big red flags that should push you further and further away from committing to an autoimmune diagnosis and making sure the patient doesn't have an infection or has a cancer. And of course, the focus, as you said, is infection. So the question is, what infections would you first test for? And it's interesting, you ask yourself, what do you do with the fact that her CT chest doesn't show a portal of entry for lung infections like TB? You recognize that TB can actually be extrapulmonary, so you have to think about it in this situation. But I'll give you a quick spiel about granulomatous infections. They all come from the outside, all of them. And the most common portal of entry is the lungs. But there are 3 other ways granulomatous infections can enter your body. And I'll give you examples of each category. Skin, Bartonella, cat scratch. GI, food, brucella. GU, many, but my favorite is when you instill Mycobacterium bovis as treatment for bladder cancer. We've had that on VMR. So I think in this case, before you diagnose anything else, you need to get Bartonella, brucella, and even chlamydia psittacoccus serologies before you exonerate and start to think about autoimmunity. Why? Because of the reasons we mentioned, but more importantly, her epidemiological exposure. She works in the poultry industry. She has birds, she has dogs. You really need those serologies before you move forward. So I think if I had to make an educated guess, I think that this would be a very beautiful presentation for brucella, primarily because of the poultry exposure and the possibility of interstitial nephritis. It's a notorious cause of interstitial nephritis, but it could be anything. The only thing that you know is your distance between an autoimmune diagnosis should be far. You may end up getting there, but there are too many red flags to jump to that conclusion. So what I'll conclude is congrats to you, Hee Mun, for not falling into the trap, I think, of calling this autoimmune and still holding infections. And whenever you're holding infections, TB should be the most concern. Here, her epidemiology broadens that concern to some other infections. David, the mic is yours, my friend.
Yeah, great discussion. So, Ravi made the key point that this is clearly like very profoundly epidemiological driven. So the test that was done in this case was bone marrow biopsy with Leishmania PCR and Leishmania culture, and Leishmania was strongly positive, and yeah, they did see the mastigotes in the bone marrow. So yeah, Leishmania is very common here in Spain, and especially in the area in which my hospital is. So yeah, this was not like not so difficult to think of if you're like in my hospital, because yeah, it's very like not uncommon. But yeah, I think the diagnosis here will depend a lot on the epidemiological background of the patient, and the key thing here was to first to think of the uncommon combination of granulomatous diseases and glomerulonephritis slash like interstitial nephritis picture, and the crazy antibody stuff that also is very typical for these diseases. So yeah.
And like I said, I think this is one of my favorite cases. Just the way this story is unreal. I didn't know that leishmaniasis was this prevalent in your region, Debbie. This is absolutely incredible, and I'm embarrassed to have not thought of that, because the only case of leishmaniasis that I've ever seen was at UC when I was a R2, and it was a patient who was ultimately thought to have acquired it in Spain. And I only remembered that after you said it. So wow, what an incredible story. Just for the sake of time, because I know he has to leave for her rotation, let me hand the mic to you, hear your reflections and what you learned from this case.
Yes, I'm always learning so much from you guys, and like I remember Jess was teaching us splenomegaly, and he mentioned about the Leishmania Kala Azar, like classic hepatosplenomegaly with pancytopenia, hypergammaglobulinemia, and yeah, I never thought of that, but it should be in my mind. But it was incredible, and Rabih, it was poetic. It was a wonderful teaching I learned. And yeah, David, thank you so much. Wonderful case.
Yeah, I just wanted to say that it was such a treat to discuss with you because you're always anchored in the reality of wanting to make a lot of progress and get to the answer as quickly as possible, but so authentic to the data. And for me, I will remember this case in terms of our dialogue as to how you resisted the urge to call this lupus, even though you said lupus in Alquat 1, and then you got positive ANA, positive dsDNA. But you still said, even though you just gave me that, there's something else going on here. And then as David taught both you and me, this is all epidemiology driven, I just wanted to take this opportunity to go back to that granulomatous schema that I shared with you. When the lungs are spared, think skin, GI, and GU, right? And so leishmaniasis is an example, maybe more common in David's area than Bartonella, of skin. So you get bitten on the skin, and that's where the bug comes from. And so you can now use that as another example of extrapulmonary granulomatous infection under the umbrella of skin. Really, really, I learned just as much as you did from this case. I didn't even think of leishmaniasis at all, to be honest. So I'm glad to have that reinforced, and we'll do a lot of reading after. David, and before we hand the mic to Magnus to summarize the learning points, anything that you wanted to reemphasize before we conclude?
No, so this what happened really in this case that was that rheumatology initially felt this syndrome with the neutropenia and also initially the splenomegaly in that. But yeah, I think this is haven't talked about that, but this was a pretty well controlled RA, and as you said from the beginning, like subacute inflammatory picture in the setting of an autoimmune disease in the background of autoimmune disease could be many things and could be definitely a complication of autoimmune disease. But first of all, have to rule out infections, and either this was a mildly immunosuppressed patient with low dose methotrexate. If the epidemiological background is there, you have to think of it. Yeah.
Yeah, absolutely superb. Thank you for that re-emphasis of the relationship of autoimmunity and systemic disease, and it's not immediately autoimmunity. I love that. Magnus, I owe you an apology. I'm actually late for work, so I made you the host. You're now the big boss of this meeting. I will check out your teaching points on YouTube. Just make sure to end the session when you're done. Otherwise, your camera will capture the ongoing reflecting that you're doing on this case.
I promise that. Have a great day, Rabih. And
Thank you.
thank you so much for a wonderful case and an amazing discussion. And for the sake of time, I'll just share my favorite teaching points. So we had this 52-year-old female with the AKI, and the urine studies showed pyuria and hematuria and dysmorphic red blood cells. So when we see pyuria along with AKI, we should start thinking about common causes. So there could be two separate causes for the two, being, for example, a UTI and dehydration. Or we could have more rare causes like interstitial nephritis. When we have hematuria along with AKI, we can also think of common causes like a stone and dehydration. Or if we connect the two, we could have a glomerulonephritis. And when we have dysmorphic red blood cells as well, that should also make us worry for a glomerular cause. But in this patient, we also learned that she had inflammatory symptoms. And taking that together with her urine studies and her AKI, we thought about a glomerulonephritis course by either HIV or hepatitis B, or it could be an interstitial nephritis caused by granulomatous infections. And here, because there was no pyuria, glomerulonephritis usually cause no pyuria, so the presence of that made us consider interstitial nephritis. And also the degree of albuminuria and other proteins in the urea made us more suspicious of interstitial nephritis, because glomerulonephritis usually causes a large fraction of albumin, so it's more selective towards that. And here it ended up being a granulomatous infection causing interstitial nephritis. So thank you guys, and yeah, have a wonderful day, all of you.
You